Okay. Hello, team. I'm gonna make this announcement part quick because we do have a lot to go over today. We're pretty much gonna do a speed run of chapter 13 because that is the last bit of lecture that we actually have for this semester. Um, so missed last week, and I did record an audio lecture or a video lecture, I should say, for the last half of chapter 10. I just haven't posted it yet. I'll probably post it it's the same time I post this one, which will hopefully be later today. And between those two, so chapter 10 and chapter 13, that is what your test will be on this weekend. I wish it didn't have to be that way, that we didn't have to have a test immediately after. We had some time for review, but this is just one of the byproducts of this class starting so late, squeezing so much stuff in before the Greenville Tech semester ends, which I think is a lot earlier than the high schools does. But yeah, and that's if you keep taking online classes, especially that kind of comes with the deal. Just having to do some stuff on your own, unfortunately. So I'm gonna, like I said, gonna go through the psychological disorder unit today because that is on the list of things that we are required to cover for this semester, and it's also probably the most interesting. At least in my opinion, like there's an entire class called abnormal psychology that you'll probably take if you keep going through psychology in college. But yeah, so that will be what we cover today. I will add video lecture, like I said, explaining the back half of chapter 10, and then also some of paper stuff, because that will be due at the same time as the exam. And I'll also explain assignment 6, which is just sending me your paper topics. That shouldn't take too long. Let's see. I'm trying to think if there's any other clarification of things. I don't think so. Well, I mean, today will just be lecture. I'll go ahead and put this in the chat. All right, so because we won't be taking a Kahoot, which is usually how I take attendance for this stuff. And I put a word in the chat that you guys can send me. That will be my way of knowing that you were here. Send it on Blackboard or regular email. Either one of those is fine. But if I get that, I'll be able to mark you as having come to class. Yeah, let's go ahead and get into it. Now, you'll probably have questions. I will probably have to hold off on those for now. And if you email me, I will definitely be responding to those a lot more quickly because I have caught up pretty much completely on grading, which took a while, but I did it. So pretty much all your assignments that have been done up to this point are graded. So I will be a lot more responsive to emails. Just been getting a lot of those from my 3 classes. It's been kind of hard to keep up with, but I think we're in a better spot now. So if you have questions, feel free to send those my way via email. But we're gonna go ahead and start because there's a lot to get through. So psychological disorders. We're talking about abnormal psychology. Okay, so I didn't choose that word. It's probably, I would think would probably get changed sometime in the future just because we're going to talk about stigmatizing things and words and how words are important, and the ones that we choose to use impact the way that people perceive a lot of these disorders. So what's a psychological disorder? It is symptoms basically that are distressing in terms of social functioning, work endeavors, and other aspects of life. So we'll talk about the 3Ds of diagnosis and how those sort of comprise how we interpret a psychological disorder. I was going to say something here. So even when we're talking about classification of these disorders, a lot of therapists, a lot of clinicians tend to not want to identify so strongly with the names of the disorders themselves and want to focus more on the symptoms. So symptoms is the key word there, because that is largely what we're dealing with instead of just dealing with obsessive compulsive disorder. you're mostly treating someone with specific symptoms. And when we get to the DSM-5, talking about actual classification, we'll talk about why that is kind of controversial. But abnormal psych, like I said, is the academic field for psychological disorders. So the 3Ds of psychological disorders are dysfunction, distress, and deviance. This is important. This will definitely be a test question. Dysfunction is pretty much the degree to which it affects like daily functioning. And so things like your school or your social relationships or your work, like if you have something like major depressive disorder and you're too sad to get out of bed, that is going to cause you real world logistical problems. So we would call that dysfunctional because it is messing up your daily patterns. And presumably because of those more practical effects, that would cause you some emotional upheaval. So we would call that distress. So distress is sort of the cognitive emotional element to all of this. And then deviance is a weird word, but basically what that means is it is how far outside what we would consider the normal range of behavior is. And so then that refers back to typicality, which is the top here. And so the degree to which a behavior is atypical, meaning rarely seen or statistically abnormal. So this is subjective. So this changes from culture to culture. We'll also talk about how it can change even from person to person. But typicality is just sort of this range. It can be if we take like a personality inventory or some type of test, it can be a range in that sense, or it can just be a range according to like the parameters of the DSM-5, which we'll also talk about later down the road. The typicality is, like I said, subjective and kind of hard. Yes, Zach, I can do that. Let's ask about the chapter 10 learning curves. I can absolutely fix that. That takes like 2 seconds. All right. Okay, part 3. All right, so deviance, we talked about deviance, how it, we're talking about things that are outside the norms of psychological behavior. So doing deviant things is not 100% all the time indicative of a psychological disorder. So if you're like a high achiever, like really good at sports or school or something, that's technically deviant. That is outside of what we would consider a typical range. But that does not mean that you have a psychological disorder. So pairing all of those things is sort of how we determine whether or not somebody gets diagnosed. So if you come in and you say, I'm exhibiting X symptom, we would probably look to combine that with some sort of emotional distress that's caused, and then also how much it is affecting your daily function, and then how much it is outside of our normal range. Anybody can have these. So there's an important point here to separate the idea that if you are experiencing anxiety, that's actually completely normal. So if you have a big test in the morning and you're nervous about it, that you probably don't have a psychological disorder because of that. That's like just normal human behavior. Where it becomes disordered is when it's sort of an irrational fear, which we'll talk about when we actually get to anxiety specifically. But so a lot of these symptoms that we talk about aren't necessarily deviant on their own. A lot of times it's the cause. That's the thing that wouldn't necessarily predict that level of behavior or even the extent to which you experience those symptoms. So if you have a loved one or a pet that passes away and you're quite sad about it, that's normal. So like grief is a thing that kind of confounds a lot of this. But yeah, we would not say, okay, well, you have major depressive disorder because you are experiencing grief over the loss of somebody you care about. Like that's normal and healthy. Yeah, it exists on a continuum. As we get to sort of the ends of the spectrum, we'll call that more abnormal, and normality changes throughout the world. We'll talk about this idea of Taijin Kyofusho. It's sort of the Japanese equivalent of social anxiety disorder, which we'll talk about more later. There are conditions that are specific to specific cultures, but there are also just sort of contextual factors that determine how we interpret a particular disorder. All right, stigma, this is an important thing. And like kind of going back to that cultural discussion, a lot of these stigma come from how psychological disorders are perceived culturally. So a stigma, negative attitude or opinion about groups of people based on certain characteristics that they have. So a pretty common one is that like people with psychological disorders are more likely to be violent or aggressive, and that's not true usually. Usually violent behavior is more indicative of some type of substance abuse, be that drugs, alcohol, what have you. It's very rare that a psychological disorder is specifically a predictor of violent behavior. But because of the way that it gets portrayed in a lot of movies and TV shows, that somebody, if they're bipolar or has antisocial personality disorder, that they are violent and a threat or scary. Think like the Joker in The Dark Knight. Like I think even Heath Ledger described him as being schizophrenic, which is not helpful to someone who has schizophrenia because they're not inherently more violent. And so how do we determine what actually qualifies as a psychological disorder? We use this thing called the DSM-5. So it's the Diagnostic and Statistical Manual of Mental Disorders, DSM. It's on the 5th edition. And so there have been updates to a lot of these disorders over the years. And just incidentally, I want to go back a little bit here. There are on Blackboard there's a link to a bunch of crash course videos, which we haven't watched any of those in here, but they're really helpful. Hank Green and Complexly put those on YouTube. So they have there's probably 40 or 50 minutes of content on all of these disorders. And so they go through the anxious disorders, they go through the depressive disorders, and just kind of give you a rundown, a lot of really good context as well that we don't have time to get into here. But I mentioned that because the DSM-5 at its inception, which was in 1952, they talked very differently about psychological disorders 70 years ago. And they also, certain things that we would not consider to be a psychological disorder now, like homosexuality, were then. And then things that did not exist then or didn't exist to the same extent, like autism spectrum, are obviously now a lot more developed 70 years after the fact. So in what ways is classification useful? Well, if you're trying to get insurance to cover your trip to the psychiatrist, or if you're trying to get like an individualized education plan, an IEP in school, some type of accommodation, that's when it's useful, because a lot of times they have certain parameters according to a diagnosis that they are looking for you to hit. And a lot of times it's the DSM-5 that those diagnoses get measured against. We'll also talk about some ways that it is not super useful. Psychological disorders are not uncommon. The biggest thing that I would ask you here is what is the most prevalent of, which type of disorder is the most prevalent, and that is anxiety disorders by a pretty wide margin, as you can see here, by a factor of 10%. Comorbidity is also something we've talked about in the past. So being diagnosed with 2 disorders simultaneously, it's not super important that you know which ones usually go together, but generally how this would work is if you have something like ADHD and it's significantly impacting your schoolwork and your social relationships, you might also, because of that, be experiencing a lot of sadness, and then eventually that might manifest itself in something like depressive disorder. So anxiety, ADHD, depression, those things are frequently comorbid. They can have a causal relationship even, but the main important thing is that you know what comorbidity is. And we've talked about it before. Okay, so the causes of psychological disorders, otherwise known as etiology. So how you acquire a disorder and how it comes to be. So there's 3 main ways we're going to talk about this. So the medical model, that's the biological stuff. So like genetic components, treating it with medicine, neurochemistry, things like that. The psychological factors model, so that is the cognitive element. So think like Freud, a little bit of that. So that would be a pretty much solely cognitive approach. Early childhood experiences, personality characteristics, things like that. Internal thought processes that lead to these disorders. Hey, come here. Hey, mate, come here. Come here. Come on. Okay. Then the sociocultural factors model. So a lot of times, either in the actual onset of a particular diagnosis or the proliferation of it and the treatment of it, what kind of social setting you're in can significantly impact how psychological disorder manifests, or even the extent to which you experience those symptoms. So the combination of those three is called the biopsychosocial perspective, which is where we'll talk about that a good bit. You can kind of see that and how it works. It's the most comprehensive, the most holistic approach, probably the one that gets used the most often because it's the best. Not that I'm biased, but you can kind of see the different things that go along with each one of those approaches individually and then collectively as the biopsychosocial approach. All right, we're going to talk about One Direction. It's not 100% true, but Zayn Malik does have anxiety disorder. So how do we differentiate between normal anxiety and anxiety disorders? Okay, because like I said, having anxiety about a big test or a big interview for a job that you want is normal. So how do we determine what isn't normal? So there are, the key word here is irrational. So if it is a fear that is to be expected in a given circumstance, that's a rational fear. But if it's something that you are fearing that's ridiculous, like if you think you might die if you go to that interview for that job or take that test, that's not a rational fear. That is, thank you, definitely irrational. Or you might experience a rational fear to an irrational extent. So having just sort of this really debilitating fear to the point that you might not be able to get out of bed or leave the house to go take that test or go to that interview. So the 5 that we're going to talk about: panic disorder, specific phobia, agoraphobia, which is a kind of specific phobia, social anxiety, and then GAD, generalized anxiety disorder. So this is just a table that shows you the prevalence of all of these disorders. As you can see, the biggest ones are social anxiety and specific phobias. So panic disorder. It's a psychological disorder with recurrent unexpected panic attacks and fear that can cause significant changes in behavior. So the biggest hallmark of panic disorder is this panic attack. It is a psychological disorder, but this has a very significant physical manifestation. So the symptoms of a panic attack are very similar to those of a heart attack. So you have heart rate increase, sweating, shortness of breath, chest pain, nausea, lightheadedness, and fear of dying. Okay, so the key important point to this is that there's no specific trigger to a panic attack. So that would separate it from something like a specific phobia. So if you are socially anxious or you're afraid of spiders or something like that, and that causes a panic attack, we probably wouldn't diagnose you with panic disorder. Because panic disorder, there's things that, that, like I said, there's no obvious trigger. There's no one thing that you could point to and be like, aha, that was the moment that led to this panic attack. Sometimes it just happens. It can have a specific trigger, but the thing that would separate panic disorder specifically would be that it doesn't have an obvious trigger. Slightly important point here, maybe related to a smaller amygdala. So amygdala is the part of your brain, I believe it's in the limbic system, that regulates your fear response. So if you have a malfunctioning amygdala, that is going to lead to you not being able to process fear correctly. Because like I said earlier, normal amounts of fear, good. Sometimes it's okay to be afraid. But if you are experiencing that to an irrational extent, then we might have a problem. Right, specific phobias. This one's pretty easy to understand. This is fear of something specific. Okay, specific anxiety related to something. So if I was afraid of dogs, don't know why I would be, but I would have cynophobia. How this can happen: classical conditioning. So just some sort of associations. We talked about the Little Albert experiment. How you can develop these through associations, operant conditioning, observational learning. So if you have somebody in your family that has a specific phobia, and they've talked to you a whole bunch about it, you've observed them experiencing the symptoms, you might also acquire that phobia. And then evolutionary explanation. So a long time ago, when like snakes and big cats and stuff were a lot bigger threat to us, we might have internalized the idea that we should be afraid of them, and then evolutionarily just kind of stuck with us. So all of these things can combine to continue to create these phobias. But you can kind of, I probably wouldn't ask you on the test, like, what's it, what's the name for the fear of dental procedures, but just having a general idea. Agoraphobia, probably the one exception to that. We'll talk about that right now. Agoraphobia, really the big point there is that you're afraid of public spaces. So think less like, think about like a fear of going to the supermarket. Okay, so it may result in panic-like symptoms. So we talked about panic disorder. So those may come up. People with agoraphobia usually need somebody to accompany them to go to places like the supermarket, and they may show avoidant behavior. So we talked earlier about if you have a specific phobia or if you have social anxiety, avoidant behavior is basically just not putting yourself in positions where that fear you would come into contact with the thing that you're afraid of. And this happens with a lot of psychological disorders. There's a lot of avoidant behavior. So if you are, let's say, socially anxious, you wouldn't go to a party because you're putting yourself in a position where you might get more anxious. If you are scared of spiders, you wouldn't go to a place where there were a lot of spiders. Basically, that's the idea there. Avoidant behavior. But that would also obviously create a lot of distress. You can't avoid everything. You can't, if you're afraid of taking tests, that's going to cause some problems in school, and you can't avoid that forever. All right. There we go. Okay. Social anxiety, another specific phobia. The key point here is that there is an irrational fear of judgment in a social situation. Okay. So it might, people not going to a party, people not wanting to start conversations with strangers because they have a irrational fear of being judged and have overestimated the potential undesirable consequences of those interactions. Most of the time, social interactions don't have these like high stakes that people with social anxiety think they do. But again, this is a disorder. And so this is, they're not thinking about these things rationally. It's just part of their daily experience is to be afraid of these things. All right, generalized anxiety. So this, as the name would suggest, is not confined to one thing. This is anxiety across a number of domains, like family, health, school, other aspects of daily life. That sounds kind of broad because it is. There's a lot of things to be afraid of with generalized anxiety disorder. So there is a genetic predisposition to this. Parts of the brain like the amygdala and hippocampus, which helps govern memory, might have some sort of issue with development. There's some neurotransmitter activity that might have an issue. So you might have an excess of something like glutamate and not enough of something like GABA. Adversity in childhood and overprotective parents may also play a role because if you have never had that experience of being able to adapt to potentially stressful circumstances, you may not be able to navigate them on your own. Okay, OCD. OCD starts with an obsession. So there's two components to this. There's a cognitive part and a behavioral part. So the obsession is the cognitive piece. This is what, if somebody's obsessed with cleanliness, they literally can't stop thinking about germs. That obsession dominates their thoughts. And the key point here is that it is intrusive. It's not welcome. They're not trying to think about being clean. It just happens. And then to try and alleviate that stress that those obsessive thoughts cause, they would do something called compulsion, which is the behavioral component. They do some type of activity like washing their hands that would alleviate those stressful symptoms temporarily, but eventually the cycle just starts right back over because they start worrying about germs coming back. You just continue on with that example. The obsession can be pretty much anything, but the compulsion is to do some type of behavior that alleviates that obsessive stress. And you just get stuck in this cycle, and it starts to become quite dysfunctional because if you are spending a lot of your day doing something like washing your hands to an unhealthy extent to the point that it's becoming quite disruptive, then we would potentially start to move towards diagnosing you with the disorder. Okay, so yeah, there is a significant difference between just sort of needing to be neat and having to have your desk organized and having OCD. They're very time consuming, these obsessions. They cause a lot of emotional distress and dysfunction throughout that person's day. It's not super common, about 1% of the population have it. You might have a reduced activity of serotonin. So serotonin is a mood regulatory neurotransmitter. All of these parts of the brain may be affected by it or cause that. And then genetics, there's a genetic component to OCD as well. The negative reinforcement cycle in this case is going back to that, doing the compulsive behavior to alleviate the stress from the obsession. The negative reinforcement cycle comes from, so negative reinforcement means taking something away so that the behavior will be encouraged. So if I'm washing my hands to alleviate stress about germs, I am taking away that stress by washing my hands. And so that is communicating to my brain that I need to keep doing that behavior to alleviate that stress because it makes me feel better. And so I get stuck in that cycle that becomes quite difficult to break out of without a lot of therapy. Okay, so getting into the depressive disorders, the first one we're going to talk about is PTSD. PTSD, as the name would suggest, is some type of exposure to trauma. It can be death, serious injury, violence. So symptomatically, disturbing memories, nightmares, flashbacks. It can also have a lot of similarities to depressive disorder in terms of the things that the people experience, just like not wanting to get out of bed. Also characterized by significant feelings of retroactive guilt. So feeling like they should have done something different to prevent whatever traumatic event that they saw. The example they use here is school shootings. There's a lot of correlation between being involved in a shooting at somebody's school and PTSD symptoms after the fact. People like first responders, prison inmates, and veterans, people that are in high stress, highly traumatic situations pretty regularly, show a higher rate of PTSD. Makes a lot of sense. And so so we talked about that avoidant behavior. If you are someone who has experienced like gun violence at your school, you may not want to go back to your school. So that would be avoiding environmental cues linked to the trauma. That's very common with PTSD. So we'll talk about dissociative amnesia a little bit later when we get to the dissociative disorders, but people who have this disorder tend to sort of dissociate away from their experience of that event. So sort of this like fractured consciousness, basically. They have unrealistic self-expectations. We talked about them sort of editing the story, thinking that they could have done something differently when probably that wasn't the case. And then loss of interest in activities that were once enjoyable. Okay, so we'll talk about negative and positive symptoms, especially when we get to like bipolar and schizophrenia. But a negative symptom is not just like a bad symptom, because most of the time all of these are bad. But a negative symptom is where something's being taken away. So not enjoying activities that you used to would be a negative symptom. Something like an unrealistic self-expectation would be a positive symptom because it's something's being added. Irritability and aggressive behavior. So this is one of the few where there is actually a correlation to aggressive behavior. It is largely an emotional element, trouble sleeping or concentrating. Both of those have to do with neurotransmitters like dopamine and serotonin. And then dissociative symptoms. I mentioned dissociative amnesia, how you can sort of selectively edit memory away from that particular event. Can even cause you to, sort of zone out in significant situations. All right, let's do major depressive disorder and then we'll take a break. All right, major depressive disorder. And so how do we classify this? So you have to have one major depressive episode. We'll give you some of the symptoms of those in a minute, but it has to occur for at least 2 consecutive weeks and change from prior functioning. So a lot of these we'll notice have like time constraints. That is part of the DSM-5 categorization of these types of disorders. Can cause significant distress or impairment, not related to a medical drug-related condition. It's another important point. If you walk into a doctor's office and you tell them, well, I've been experiencing delusions and hallucinations, and I have just felt like really spaced out recently, and I think I might have schizophrenia. And the doctor is going to be like, okay, well, have you taken any drugs lately? And if you say yes, the doctor is going to be like, well, you probably don't have schizophrenia. It might be the LSD that you've been taking. So any type of other medical condition or drugs that you might have consumed, or medicines that have side effects. So if you take an allergy medicine and the side effect of that allergy medicine is depressive symptoms, then your doctor needs to know that. And so they don't diagnose you with major depressive disorder. They can just be like, maybe let's change allergy meds so you don't continue to experience these symptoms. But a major depressive episode, you have to have, what I think it's 5 of these. Yeah. So depressed mood, it's a negative symptom, reduced pleasure in activities. Most of these are going to be negative symptoms because depressive disorder is just kind of a negative disorder typically. Substantial shifts in weight, excessive sleeping, feelings of fatigue, feeling worthless, difficulty concentrating, but persistent thoughts about death or suicide. And also note here, if any of these disorders that we talk about sort of trigger something in you, or you read some of this and you're like, huh, it kind of sounds like me, I would encourage you to talk to your counselor at your high school, and then you talk to your parents, maybe get an appointment with the doctor to actually talk through that stuff, because that's important. Getting help is important. All right, so distinguishing grief, we talked about that. Grief is a rational thing to be sad about. So if you lose a loved one, if you lose someone you care about, like, that is totally acceptable and normal for you to feel significantly sad. So this idea down here at the bottom of absenteeism, presenteeism. Okay, so absenteeism is when people are too depressed to go to work. Presenteeism is when people are still going to work, but their depression is preventing them from being good at their jobs. So this costs a lot of money and time on people doing either one of these things. So a lot of, in America especially, our culture is just kind of like, yeah, power through, go to work. But it's not helpful if you are in a depressive state, even have depressive disorder, to just continue to go on through your life like nothing is happening, because you are not going to be the same person. You're not going to be able to contribute the same effect that you would if you weren't experiencing those symptoms. And the moral of that story is to get help if you are not feeling like yourself. All right. All right, so there's a significant degree of heritability. So heritability is not just a risk for getting a psychological disorder. That is part of it. But it's more so if you get a psychological disorder, how much of it is linked to your genes. So if I have major depressive disorder and the heritability is 37 to 50%, so there's a 37% chance that it came from my genes, but there's also 50 to 60% chance that it came from something else. But that being said, there is a significantly higher risk with depressive disorder if people close to you have it. Hormones, we haven't talked a ton about the HPA system, but these are hormones. Hormone system gets from your hypothalamus to your pituitary gland to your adrenal glands. We talked about hormones way back in chapter 2. So this, for my ladies in the class, this is why postpartum depression is such an important thing and such a common thing. Stress into having a baby is quite stressful. It also significantly changes the hormone levels in your body, and that can affect your mood significantly. That's why after the fact, after they have a baby, women are really commonly depressed for quite a while, and that's fine. Particularly those associated with pregnancy and childbirth. So this is the sort of the holy trinity of depression and neurotransmitters are norepinephrine, serotonin, and dopamine. So serotonin, we talked about that. It's a mood regulatory neurotransmitter. Dopamine is, it does two things major. It's your major mood boosting neurotransmitter. So your happy neurotransmitter, basically. One of the reasons that drugs like cocaine are so popular, because they keep more dopamine in your brain. But if you are not getting enough of those good feelings, there's a significant chance that you'll get depressed. Norepinephrine is part of your fight or flight system, but it's also just kind of helps you get excited. And if you're depressed, you don't get excited about the things that you normally would. And that's part of the problem. There are structural differences in the brain as well. Okay, so this idea of learned helplessness is also part of this. Don't ask me to explain this experiment, it's really depressing. But there's a tendency for people to believe they have no control of the consequences of their behaviors, resulting in passive behaviors. Basically, these dogs learned that through this experiment that they were just going to get punished no matter what, and that their actions didn't have any agency in their situation, and so they just stopped trying. Which is Seligman, who put on this awful experiment, also just extended this out to people, and he's correct that in somebody who has major depressive disorder, they are likely to just believe that their actions don't have any impact, and they will just instead choose not to act. All right, last thing we'll talk about, and then we'll take a break. So Begg's cognitive triad. This is sort of this triangle looking thing that just perpetuates this cycle of negative automatic thoughts. So negative automatic thoughts, things that are intrusive, that you're not intending to think about, that you are having bad feelings about yourself because of something that happened to you. And because of that, you are not going to feel good about the future. So if you get a bad grade on the test, you might think something like, I'm dumb, or I'm just not good at school. And then, so when the next test comes around, you will be sad and then anxious and things like that. One of the reasons that this cycle is so hard to break, because that just keeps perpetuating. Okay, because then you'll do bad again, continue to think that you're stupid, and then you'll continue to be afraid of that next test coming around. Especially when it comes to negative life events, like this says here, breaking out of that cycle can become incredibly difficult. Way people respond to their experience of depression may impact the severity of the disorder. That's true. So they use this example of women and rumination. So typically, my ladies in the class, you guys are a lot more thoughtful and think about things a lot more than we do, because we're most of the time just kind of blunt instruments. Men also ruminate. That's a thing that the book doesn't really talk about, but we do. But typically women struggle with depression longer because of this idea of rumination. Okay, so that is most of the sad stuff. When we get back, we'll take a break. We'll come back at 9:30, give you all a nice 7-minute break to cool down before we get into bipolar and personality disorders, mood disorders, dissociative disorders, and then finally at the end, eating disorders. Okay, I will see you guys at 9:30. See ya.